Hi, everyone. We're back with another episode of Fertility Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility, and today I'm joined by my splendid and dazzling friends, Dr. Susan Hudson from Texas Fertility Center
Hello.
and Dr. Carrie Bedient from the Fertility Center of Las Vegas. How you
Hey,
doing?
y'all. We're doing
How's
good.
it going? I heard you went somewhere fun yesterday, Susan.
I did. My town that I live in, we had our first annual, which I always love it when it's a first annual Renaissance Festival. And so it was one of those things that you're like, okay, I'm not exactly sure how this is gonna, how big or how small it was. I have to say it was way bigger than I expected. They did a
Ah,
great job for their first year. I have to say it was probably 4 times as big as what I expected. And they didn't expect nearly as many people to show up. It opened on Friday and we went on Saturday. We got there about 2 hours after it opened and stayed for about 2.5 hours. And when we left, there were like droves of people coming in still. But it was neat. It was fun. I mean, it's not like the big Texas Renaissance Festival because that's been there for like decades and very well established. But it was neat to see something that was brand new.
Did you dress up?
I did not dress up this time.
Not even like a crown or tiara
I,
or a wreath of flowers or ribbons or something? Like not even a little bit?
not this time. Not this time.
okay, so I have to ask this. I'm a Renaissance Festival virgin. I've never been to one. We have one in Nashville, but I've never been to
You
one. So, like,
totally have to go.
We've
They're
never been
so
to
much
one.
fun.
what do you do? What do you do at a Renaissance
So,
Festival?
so they have a lot of the Renaissance Festival is they have lots of artisans, whether
Oh,
it's
okay, that'd be
jewelry or
cool.
knives or
Oh,
clothing or
maybe
hats
not knives in my case. Jewelry, not knives though.
or
There's your
you
sense of
know, you need to
adventure.
do a little
Yeah.
fencing here and there. But yeah, so there's a lot of artisans who go there, glass blowers, pottery
Oh,
makers, those
that's
types of
cool.
things. And then at the big established ones, this one had a few things, but like there's always like a birds of prey type of
Oh,
demonstration.
okay.
There's
They have
usually jousting.
sword fighting and
Oh,
jousting and just all kinds of. They usually have like a thing where lots of music and that type of
They,
thing.
they usually have a bar telling stories and
yeah.
funny
Okay.
tales and
And
things like
fun food
that.
and turkey legs and gyros
I've
and
heard about the turkey legs, like they're giant turkey legs and
yeah,
stuff.
you
Yeah,
definitely need to go. Maybe we need to
yeah.
do a
Okay.
field trip.
That'd be
I would
fun.
be okay with
Yeah.
that.
Yeah,
I
yeah, yeah.
always wanted to know, is there somewhere where there is a turkey farm specifically for Renaissance fairs where the turkeys are the size of horses? Because when you think about these turkey legs, like I
There's
do not have a lot of up close and personal turkey experience. However, I did not think that turkeys would be that big to support just a portion of their leg to be like that. And so I feel like somewhere there is a turkey farm with turkeys as large as like cows and horses.
I was just thinking, like, what do they? I imagine they use the rest of the turkey to make like sandwich meats and things like that, because you're not going to sell like just the turkey without the legs.
I mean, turkeys are not small birds. We actually have a lot of wild turkeys in Tennessee, and they're not small birds. I mean, they're not the size of horses, but they're like big, gangly, like, and when they roost, when they fly and roost in a tree, it's like the whole tree goes because they like, there's like a whole flock of them, and they're just awkward and gawky, but they're big, kind of lanky birds.
I thought that the wild turkey in Tennessee was just like bourbon or whiskey.
Well, that too, but we have that's the real turkeys as well. In fact, it's actually pretty common to see turkeys in the fall and the
We
winter to
used to,
see
we used
turkeys.
to have wild turkeys in our neighborhood here in Texas.
Yeah.
Seen them in the last few years, but yeah.
See,
Yeah, in my
Carrie,
neighborhood, imagine wild turkeys more like in a Wile E.
yeah.
Coyote scenario where they're getting chased by coyotes.
See,
We have coyotes too.
Carrie sees like lions and tigers in her neighborhood. We just see wild turkeys
And bears.
and bears. Yeah.
You actually really do
Hey,
have bears, don't you?
here? No,
Yeah. No
Oh, you
bears?
don't? Oh, we
no
have
bears.
bears. A few
No,
bears.
I mean, you may be thinking of the story where my husband and all of his family were in, I think they were driving through Yosemite or some other big national park, and
Um,
they walked up to a bear because they thought that that was a good
Yeah.
idea. I
No.
was
Not a
Yeah,
good idea.
that happened at least 2.5 years ago, and I'm still kind of pissed about it.
All right. Well, we digress. I see Susan looking for a question. We'll
I
move
am.
on.
All right, here's our question of the day. Hi, docs. Thank you for the podcast. It not only provides invaluable information as I trudge through my own fertility journey, but also provides hope. Well, thank you so much for listening.
Yay.
Here's my situation in question. I've had 3 miscarriages this year, a blighted ovum, a biochemical, and one at 6.5 weeks after a successful IUI cycle. I've had the full recurrent pregnancy loss workup. My husband had a semen analysis, and we did genetic carrier screening. Everything is normal. We're moving forward with IVF, including PGTA testing of embryos to hopefully give us better odds. My question is, in my first and third pregnancies, I had a subchorionic hematoma, and I'm wondering if this points to an issue with my endometrial lining. Should we do an endometrial biopsy?
Well, subchorionic hemorrhages we see pretty commonly. I mean, in fact, I think probably in the general population, if they had early 6-week scans the way we do on our patients, we'd probably find tons of subchorionic hemorrhages. And most of the time, those really don't amount to anything. Most of the time, they're just kind of a finding, and baby's heartbeat looks great, and the pregnancy continues on. And certainly we don't like to see those, but most of the time, in my experience, when we see those, things turn out fine. The only thing that when a patient calls about that, I would say we need to check your blood type, make sure that your blood type is positive and not negative. If you have a negative blood type and your partner has a positive blood type, then we need to give you some medicine. But really, hemorrhages are pretty common. I would say the great majority of hemorrhages don't amount to anything negative, and it's just a coincidental finding because we're looking so early.
I would agree with that. When I was first a fellow, I remember seeing those and then starting to give patients the, well, this might be a miscarriage, da 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 da. And now I'm just like, oh yeah, whatever. I don't care. Like I don't care until it's a problem that I have to care about, because for the most part, they just sit there causing anxiety, and that is the worst
Yeah.
thing they do, which is not to be discounted because it's kind of a lot of anxiety. But they are so very common. I mean, regular OBGYNs don't really care about pregnancies until you hit the 10 to 12 week mark, because that's the highest risk time period. And until you get to that point, they're not sure that things are going to stick and go forward. And so we are the primary ones who do those scans. And so we're the ones who see them. And so we see them so frequently that it's not, in general, it's not really going to cause a ruckus unless it's really huge, like several times larger than the pregnancy itself. And just as the baby grows, the chorionic hemorrhage gets smaller in comparison, and then it just resorbs.
So I'd like to make 2 comments. So as somebody who had a subchorionic hemorrhage with my IVF pregnancy, my daughter is now 13, and I remember that day like it was yesterday. So please don't think we're discounting it, because it is scary as hell. Like I said, I remember that day vividly. And you can have a crazy amount of bleeding sometimes with those subchorionic hemorrhages, but realistically, most of them do go on to be normal, healthy pregnancies. So, like I said, we don't want to discount what happens in a subchorionic hemorrhage. And certainly some people may go on to have miscarriage, but the vast majority of those are not necessarily going to result in that. As to an endometrial biopsy with recurrent miscarriage, I know we've talked about Receptiva in the past on episodes, and the presence of BCL6 can be related to recurrent pregnancy loss. So that's probably not a unreasonable thing to take a look at. Also, make sure there's no chronic endometritis that's going on or anything like that. So those are some reasonable tests to take a look at with an endometrial biopsy, in addition to potentially the things that you've already looked at in your recurrent pregnancy loss evaluation.
Very good. All right. So today we're going to talk about prediabetes and diabetes. We see lots of people that have those conditions, and there's lots of questions about those, and we don't think we've ever even done a show on it before. So I guess why don't we start out and just tell our listeners what prediabetes is versus diabetes?
So I'll start this off. So the first thing we're going to start talking about is something called hemoglobin A1C. Okay. So what your hemoglobin A1C is it is a marker of your average blood sugar over the past 3 months. So a lot of times people come in, we may check your hemoglobin A1C just to see where you're at. And people are like, oh, it was just elevated because I ate beforehand, I wasn't fasting, or I did something naughty, 3 days before or something like that. And that is actually the beauty of the hemoglobin A1C, because what it is looking at is what's called the glycosylation of your hemoglobin molecules in your bloodstream. And that's over a 3-month time period. So you can't cheat. you can't make it abnormal or normal by doing something for only a few days. Okay, so that's the reason why a lot of us use that now as our major marker, because it's relatively foolproof. Okay, now as to the foolproof, if you have severe anemia, so a low blood count, then it's possible that your real hemoglobin A1C may be higher than what it's actually detecting. So that's the only kind of part of the foolproof that may be an issue. When we're looking at people who have either diabetes or prediabetes, we have certain numbers that we're looking at for those hemoglobin A1Cs. So a normal hemoglobin A1C is going to be 5.6 or less, okay? If you are in the range of 5.7 to 6.3, then you're in that prediabetes range. And if you're 6.4 or above, that is in the diabetes range.
So Carrie, tell us what the difference is between prediabetes and diabetes.
It's really just how effectively your body deals with blood sugar. And when we say sugar, we are not thinking about, the granulated sugar or powdered sugar that you buy in the store. What we are thinking about is the building block of all carbohydrates. And people say carbohydrates like it's a 4-letter word. And it's really not. And it's really not, because that's what fuels every cell in our body. And so if you go back to high school biology and you kind of remember, oh yeah, there's glucose and there's galactose and there's fructose and there's all these different sugar type molecules that combine together in varying ways to make up the stuff that we eat. All of those break down to glucose and usually something else, either fructose or galactose, but glucose is kind of the primary building block of everything. And in glucose, when we say sugar as physicians, that's what we are thinking about. We are thinking about that glucose molecule, because each cell has to take in glucose in order to power all of its organelles, which are the tiny little mini machines. Organelles are just small organs, and therefore the cell itself. And so you need glucose in order to power everything. And so when we are talking about diabetes and prediabetes versus no diabetes, we're talking about the efficiency with which your body uses that glucose. Meaning, if you dump in 1 bucket of glucose, does 100% of that get used and used efficiently? Or do you have to dump in 4 or 5 buckets just to get 1 bucket's worth of use out of it? Because there's a substance called insulin, which a lot of people have heard about with diabetics. And what is lacking is the ability of insulin and glucose to really work together for the insulin to go sit on the edge of the cell, unlock the door, have the door swing open, the glucose pour in, and then the door to close again. When you have faulty insulin production and glucose sensitivity, what that means is that the opening up of that door, the unlocking and opening of that door, just isn't very efficient. And so instead of having a smooth intake, like at the Renaissance Fair, where you want to pay your admission and go right in, you just have miles and miles of people backed up because they can't get in because the person taking tickets is not effective at their job. So it's the same kind of thing. You have the insulin sitting there, it's just not doing its job, and there's a whole lot of backup of insulin or of glucose in the bloodstream.
I think this might be a good time for us to also mention type 1 versus type 2 diabetes.
Absolutely. Abby, do you want to take that one?
Yeah, so type 1 used to, we thought it was really primarily something that you would get as a child. Now we know that type 1 can sometimes be acquired by adults, but it's more of an autoimmune phenomena, where basically autoimmune cells attack your pancreas. And so as a young child, you suddenly don't produce any insulin. And as Carrie said before, insulin is really the thing that tamps down your glucose and keeps your glucose in the normal range. So if you don't have that, your glucose gets really high, which means you get diabetic. And so a lot of times for people that get it as a child, they have to be on full replacement of insulin. They have to get insulin injections. Typically type 2 is something that's more acquired as people get older. So as the pancreas kind of wears out, it can't produce enough insulin to make the glucose stay where it needs to be. And so both their glucose and their insulin tend to be elevated. So they produce insulin, but they just don't produce it as efficiently, and it doesn't work as well. And so sometimes that can be controlled by diet, by what you eat, and really watching some of your carbohydrates that you eat and the amount of food that you eat. And then your pancreas has enough insulin to overcome that. Um, Other times you need some sort of insulin, or you need something like metformin, which is a common drug that we use in our infertility patients, and we'll talk about why we do that in just a minute. Or sometimes it is to the point where you have to be on insulin as well when you have type 2. I think the interesting thing about type 2 diabetes, in some, not all patients, if you're heavy and gain weight, that makes it more difficult for your pancreas to overcome the amount of glucose that you have. And so sometimes when people actually lose weight, they can actually sort of lose diabetes. They become, their body hormones become more normalized, and they're no longer diabetic. Whereas with type 1, once you get it, you have it and you can't get rid of it. You have to just treat it, basically.
Absolutely.
So tell me, Carrie, why is prediabetes and diabetes, why is that an issue for fertility?
So there's a couple reasons. Number one, the egg production is in part dependent on normal insulin function. And so when you screw up insulin function and you don't have that as acting quite as sensitively as it should, then you're impairing the signals for ovulation to occur. So that's one of the biggest reasons we worry about it. And you oftentimes see people who are affected by prediabetes affected by other issues as well, health-wise, whether that is obesity, whether that is high blood pressure, whether that is really elevated cholesterol. All those things kind of travel together in a metabolic syndrome. And so some of those things are issues in their own right. So for example, if your body is not managing sugar very well and not dealing with it, and you are carrying a lot of extra weight, those fat cells produce a type of estrogen called estrone, and that can almost function like a built-in birth control. And so there's all this stuff that goes along with it that we worry about. When you're looking at the diabetes itself, or the prediabetes, you worry about the ability for ovulation to occur. So that's one big impact on fertility. And then you also worry about the impact that it's going to have later on in pregnancy, because as you're thinking about this, you have to remember the baby's going to win. And that is true for like the next 18, 19 years, but it starts from the very beginning. And what I mean by that is that the baby needs to get sugar, and it's going to get sugar one way or the other. And so if there is a choice between mom or baby having really functional sugar levels, insulin levels, all of that, it's going to go to the baby. And that means that mom's going to have more sugar rolling around in her blood so that it can preferentially shunt to the baby and power everything that has to happen with a growing pregnancy.
Because it takes a lot of energy to grow a baby.
It takes a lot of energy to grow a baby. And so if you happen to be in the early stages of pregnancy and a partner comes home and said, well, what did you do today? You can just say, I grew an eyeball, and I was working hard today. What did you do today? But that aside, women who are pregnant are more prone to a diabetes-like state because of that favoring of the baby. And so when you have someone who starts off already kind of favoring a diabetic environment, when you add the pregnancy into it, it just kind of pushes them over the edge, because the placenta is designed to help the baby grow at the expense of mom. And that is true for bone, and calcium and everything that goes there. It's true for energy, it's true for glucose, all of that. And that extends to increasing the risk of diabetes. So if you have someone who's starting out as pre-diabetic or actually diabetic, you can anticipate that that's going to get quite a lot worse by the time you hit the end of pregnancy, and that someone who maybe required tiny doses or no doses of insulin may require really phenomenally high doses by the time they hit the end of the pregnancy, in order to make sure not only is baby functioning well, but mom is functioning well as in addition.
So Susan, kind of going back to what you were starting out with hemoglobin A1C, when is it safe for somebody to get pregnant when they have diabetes or prediabetes?
Great question. So the best time, and when I'm talking about this, I'm talking about people with prediabetes or type 2 diabetes, and I'll talk about type 1 in just a minute. For both of those, ideally, we want you to have normal blood sugars, so a hemoglobin A1C of 5.6 or less. Now, um, we will occasionally let people go through with a little bit higher blood sugars, but I would say most of us have the magical number of less than 6.0 as kind of our cutoff of
Mhm.
where we think you should even be trying at that point, because we know with a hemoglobin A1C of 6 or above, you're at an increased risk of birth defects, especially cardiac defects, when you conceive.
I will add in our MFMs around here say it's okay up to 7 is what that's kind of, we used to say 6, but now they say the data supports it's okay up to 7. So somewhere in that range, 6 to
Mhm.
7.
And kind of along that lines with the type 1 diabetics, there's some more intricacies as to your individual health condition when you have type 1 diabetes. So usually in that situation, what I do is I have you visit with a maternal fetal medicine doctor who's a high risk OB doctor who's going to be following you during your entire pregnancy. They can look at what your history has been as a type 1 diabetic, how many hospitalizations you've had, how good a blood sugar control you've had over your time being a type 1 diabetic, and they'll be able to give us the best guidelines for your specific clinical situation. At what number are we going to have the best pregnancy outcomes? Now, what we know about pregnancy with people with diabetes is that when that diabetes is not under good control, is that you can also have complications not only during the pregnancy, but also complications that can impact your baby over a lifetime. And so when we're talking about issues that can happen immediately during pregnancy, we know that mothers who are carrying babies and they have diabetes, they tend to have babies that are bigger, which can cause issues when babies are trying to be born, increase the risk of C-section. If you have gestational diabetes or diabetes, you're also at increased risk of getting preeclampsia or high blood pressure issues in pregnancy that force you to be delivered at a certain point in time. And after birth, we know that babies can, when the blood sugars haven't been well controlled, as Carrie was talking about, baby's going to win. Okay. And so whatever is going on in mom is going to kind of happen with baby like exponentially. And so sometimes babies have trouble after they're born, kind of balancing their insulin and blood sugar. And sometimes those babies end up needing to go to the neonatal ICU for some care. And also, it can predispose babies to have obesity in childhood and adulthood, and even increase their risk of getting diabetes as adults. It's amazing how impactful your body and your physiology can have on that little growing being.
So, Carrie, going back to what we were talking about with infertility, in what ways does diabetes, prediabetes, and sort of obesity, which can sometimes go along with that, in what ways does that impact infertility for our patients?
So when you have that group all traveling together, number one, it is often much harder to maintain your weight in either direction. I mean, oftentimes new diabetics, especially type 1s, are just rail thin because their body is not they're taking in insulin, they're taking in sugar, glucose, but they're not using it at all. And so
Hmm.
sometimes you can go very thin, sometimes you can gain weight considerably because your body is not well calibrated in how much insulin it is putting out. And so it's just pouring out, pouring out, pouring out insulin. And sometimes it works really well and you're taking a ton of extra sugar and you gain the weight associated with that. And keep in mind, this is all the sugar is all on the level of glucose. So there is in no way implying that you are just like hand over fist shoveling in powdered sugar. Um, this is all just how your body is handling it. And so when you deal with it with infertility, if you have that decalibration or that poor calibration, the body has a really well well balanced machine of everything's got to be going right in order for you to be able to ovulate and carry a pregnancy, because if mama ain't happy, ain't nobody happy. So if mama's not getting the appropriate amount of sugar in, whether it's too much, too little, just right, then then she's not going to ovulate. And so that really impacts our fertility patients, because if you can't ovulate, then right there, you can't get pregnant with that. And so that's one of the big ways that it impacts fertility, just on a sitting around daily basis. And then you've got all the ways that it can impact infertility when you're looking at treatment methods, where when we give medications to induce ovulation, so think Clomid and Letrozole, there are patients in which that doesn't work. And sometimes you see it in PCOS patients, sometimes you see it in our diabetics and pre-diabetics, sometimes you see it in patients who are carrying a lot of extra weight. But a lot of it really does go back to glucose and insulin balance. And are they working together well, or are they not? And so we oftentimes find that we have to give stronger medications, actual direct duplicates of the hormones produced by the brain in the pituitary, FSH and LH. We actually have to give duplicates of those medications through injections in order to get the end effect of ovulation that we're looking for. And that's important for a bunch of reasons. Number one, it's giving an injection versus taking a pill, which nobody opts for that, that scenario if they can avoid it. Those medications are a lot more expensive. Those medications they're a lot more effective, but that's a double-edged sword, because sometimes the way that they're so much more effective is you hyperstimulate and you get a ton of eggs on those ovaries. And I tell all my patients, like, look, I want you to have a baby. I do not want you to have a basketball team. And so,
At least not at the same time.
yeah, not at the same time. If you want a whole basketball team and you're going to do it singles, fine. I'm here for you. I will help you with that. But we are not doing a single basketball team in one shot. I do not want you on the cover of Time magazine, and I sure as hell don't want to be there with you. So we're going to do this one at a time. And when you start to give those injections, you hit that powerful kind of response, and that can be very dangerous, and we don't want you to be there.
So, Susan, some of our patients are probably sitting there going, well, they talked about PCOS and they talked about metformin, and I'm having trouble ovulating. Do I have diabetes? Can you talk a little bit about the interplay of like why we as fertility doctors may prescribe, medicines that are normally used for diabetic patients when somebody's really not truly diabetic?
Right. So, we do use those medications, and sometimes we use supplements. So metformin is a medication that we often use as an adjunct, or an additional medicine while we're trying to help you get pregnant. Sometimes we may recommend some supplements like inositols, like ovasitol. And the purpose of both metformin and inositols is it helps actually your cells become more receptive to things like insulin and to the medication. So hopefully we can use lower dosages and avoid those things that Carrie was talking about, like overstimulation or hyperstimulation, and be able to give you a safer journey. Now, another thing to know though is a lot of times, I don't think you'll probably experience this if you go see a reproductive endocrinologist, but sometimes if you're seeing your OB-GYN for your fertility care at this point in your journey, that oftentimes they'll give you metformin as a first line to hopefully make you ovulate. And from our experience and a lot of good research is we know that metformin is relatively good at helping people have regular cycles, but fertility rates are only minimally, if any, impacted by the use of metformin. So metformin is really good to be used with something, whether it's Clomid or Letrozole or the injectable medications. But if your goal is pregnancy and not just having regular monthly cycles, you're probably going to need something else added into that formulation.
So, Carrie, what role does prediabetes and anovulation kind of play with infertility? Like some people may be listening thinking, well, maybe I've got diabetes and that's why I'm not ovulating, that's why I'm not getting pregnant. What role does that really play in terms of fertility?
So whenever we have someone where we run the tests, and you guys know us, I mean, you come in and see us and we're like, great, let's be a vampire. Give us 9 vials of blood. And part of what we're looking at is all of your diabetes testing. And we want to do that up front for the primary reason if we want to optimize you for pregnancy, because when we are talking about doing fertility testing and fertility treatment, we want to make sure that you're in the best possible situation going forward so that once you do get pregnant, you can continue safely. And so for all of the reasons that we've been talking about, where you don't really want to be diabetic in pregnancy any more than you absolutely have to for impact of your own health and your baby's health, we want to optimize that ahead of time. So for infertility, we're going to do it as part of our baseline treatment in order to get you optimized, because if it's something where you can lose whatever weight, if you can get on medications that can improve your sugar balance, we want you to do that before you get pregnant, because as horrible and awful as infertility is, giving someone a diagnosis of, I'm really sorry, your baby has this really awful heart defect because, and we think it's probably because the sugars were so out of line, or I'm really sorry you had a miscarriage and it's related to really high sugars. By the time you're at an A1C of 8, 9 and higher, the rates of all of those bad things happening early in pregnancy really skyrocket. And you have had a hard enough time getting where you are. We don't want to make it even worse. And so that's part of the reason why we really check that from the get-go, and we want to optimize it from the very beginning. And so that's why we send you to the MFM docs. That's why we put you on metformin. That's why we recommend weight loss. That's why all of those things are forthcoming, because it's not just your infertility and getting you pregnant, it's the safety of the pregnancy that results.
So, a couple of additional things that I want our listeners to be aware of is if you have pre-diabetes before you get pregnant and your blood sugar levels are kind of hanging out at that level, when you get pregnant, as compared to somebody who does not have those blood sugar levels, you are over 25 times more likely to get diabetes in pregnancy.
Yeah.
And if you get diabetes in pregnancy or gestational diabetes, you are more than 75 times more likely to get type 2 diabetes. And that is actually your highest risk of that happening is actually in the first few years following your pregnancy. So it's not even one of those like, oh, who cares if I really have diabetes in pregnancy? I'm not going to get diabetes, type 2 diabetes until I'm in my 70s. This could be getting type 2 diabetes in your 20s or 30s.
Yeah,
And
that's a great
understand
point.
that if you have diabetes as a young person, anytime anybody has diabetes, it puts a lot of wear and tear on your blood vessels, okay? And increases the risk of high blood pressure and heart disease. And, we're talking here about helping you make a baby, and we want you around for like 50, 60 more years at least to see all the wonderful things this baby's going to happen. So even though, we know you want to be pregnant yesterday, we're also trying to help watch out for your tomorrow.
Mm-hmm.
Very
And
good.
when we're thinking about medications for diabetes and pregnancy, so leading up to pregnancy, we have some more wiggle room. We can put you on metformin. We can send you to the endocrinologist and your PCPs, and they can put you on, the glipizides, the injectables, semaglutides like Ozempic and company, and all of those. Once you do get pregnant, all of a sudden everything really limits down to what we can use. And in general, the gold standard is to use insulin. And so some of the oral medications are coming more and more into favor as more research comes about. There's some reasons where using metformin in the first trimester can potentially be helpful. Some of the other oral medications I have seen used in the past, but really insulin is what has all the data behind it. And so when you have to start insulin, that's a whole other round of not just the injections of the medication every day, but it's all of the routine finger sticks to get a tiny little blood sample to say, okay, it's right when I wake up. What is my blood sugar doing now? Do I need any insulin? Okay, I just ate breakfast, lunch, dinner, a snack. It's before bedtime. I need to check and see where I am so that if I need to give extra insulin, I can. And there's multiple types of insulin. There's the short acting and the long acting. And so it's a real balance between those of what do we need to give you in order to hit that sweet spot so your sugars are running in the places they need to be. And it's for no other reason besides all the health implications. It's a pain in the neck. And
Yeah.
we don't want you to have to do any of that at all. And it means a ton more visits and communication with your doctor. And, ain't nobody got time for that. Like, who's got time for errands?
And Carrie, you mentioned medicines like Ozempic. So that class of medications, GLP-1 agonists, and some of their new cousins, the GIP agonists, it's important to know that actually you need to be off of those medications for at least 2 months
Yeah.
before you conceive. So, it's a lot of times people are like, oh, I'll just stay on it. As soon as I know I'm pregnant, I'm going to stop. Well, these medications have a very long half-life, and so it takes a while for them to clear your system. And so for the safety of your baby, if you're taking those, you really should be preventing pregnancy. And for the 2 months after you stop the medications, and then you can hit the door running.
Yeah, one other thing I would say too, when you're diabetic, we didn't really hit a lot on this, but you're probably going to be seen a lot more by a high-risk OB doctor, or at least for advanced testing during pregnancy, because that's considered as a high-risk condition. There's a lot of conditions where patients feel like, oh, it's high risk and I need to see a high-risk OB doctor. Well, this truly is a high-risk condition. And so, anything you can do on the front end by losing weight, diet, exercise, all that kind of stuff ahead of time, like Carrie said, it's really best to take care of this before you ever get pregnant. And hopefully then you won't have to have a high risk pregnancy and have a good outcome, which is what we all definitely want you to have. So I think this was a great episode. To our audience, thanks for listening, and tune in next week for more. Also, be sure to subscribe and leave a review in iTunes. We'd love to hear from you. We'd love your ideas, and give us a shout out.
You can also visit fertilitydocsuncensored.com to submit specific questions about infertility. All questions will be answered on the podcast on our Ask the Doc segment anonymously, so don't hold back. We love episode ideas. Let us know what you're thinking and what you want to hear.
As always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. All right, we'll talk to you soon. Bye.
Bye.